this is the quinolone structure having the two benzene ring attached to each other. The third carbon group have got carboxylic acid radical, and they are radicals in the 6, 7, 8 carbon side. So it's a synthetic antimicrobial having a quinolone structure. These are primarily meant for the gram-negative bacteria. Although newer quinolones, they have got fluorine substitution in one or more carbon atom, and these are called fluoroquinolones. These are the newer quinolones available, and they have got activity against gram positive as well and anaerobic organism as well. So they are primarily against gram negative bacteria, though newer fluorinated compound called fluoroquinolones also inhibit gram positive ones. The first member in the quinolone antimicrobial group is Nalidixic Acid, which was introduced in the mid of 1960s, and they have got only limited usefulness against the gram negative bacteria in the urinary tract and GI tract infection. Why? Because the tissue penetration in the other organs or tissues are very poor. They attain the bactericidal concentration only in the urine and the gastrointestinal tract. They have got low potency, modest blood and tissue levels, restricted spectrum to the gram negative organisms, and they have got high frequency of bacterial resistance. So they have got very limited usefulness. The first member of the quinolone antimicrobial group, that is Nalidixic acid. Now in the early 1980s, then the quinolone group, they are the fluoride atom was substituted in one of the carbon atom, and then comes the fluoroquinolones, and this fluoride substitution increases the spectrum of activity even to the gram positive organisms. A breakthrough was achieved by fluorination of a quinolone structure at position 6. This was the site where the first fluoride atom was substituted at the carbon atom, and introduction of piperazine substitution at position 7, and this structure is now called fluoroquinolones. Advantage of fluoroquinolones over quinolone: number one, higher potency. They have got expanded spectrum not only against gram negative but the gram positive ones, slow development of resistance, better tissue penetration and greater tolerability. Nalidixic acid is the prototype drug in the quinolone group. They are active against gram negative bacteria, especially the coliforms E. coli, Klebsiella, Proteus, Enterobacter, not against Pseudomonas. They act by inhibiting bacterial DNA gyrase. Bacterial DNA gyrase की function রয়েছে biochemistry. Bacterial DNA gyrase, what the role? Or DNA gyrase, what the role? In the DNA replication, basically when the two DNA strands are made apart, there is positive supercoiling in the rest of the strand. Now what does DNA gyrase do? They have got A subunit, B subunit. A subunit has got the role of nicking the supercoiled DNA strand, and the B subunit, they introduce the negative supercoil, and then the A subunit, they basically seals the nicked DNA strand. So they are responsible for basically removing the positive supercoiling while DNA replication. So they act by inhibiting bacterial DNA gyrase, and they are bactericidal. So there are two terms, bactericidal and bacteriostatic. Difference টা কি আছে? General pharmacology, general antimicrobial therapy. What is the difference between the bactericidal and the bacteriostatic antimicrobial? जोरे बोल. Basically, as the name suggests, static, bacteriostatic drug, they inhibit the growth of the bacteria, while the bactericidal, they are responsible for the killing of the bacteria. So they act by inhibiting bacterial DNA gyrase in the mechanism of action, and they are bactericidal. Resistance to Nalidixic acid develops rapidly. Pharmacokinetics absorbed rapidly, highly plasma protein bound, partly metabolized in liver, and one of the metabolites is active, excreted in urine, plasma half-life 8 hours. Concentration of the free drug of Nalidixic acid in the plasma and other tissue is non-therapeutic, and the usual dose is non-therapeutic to systemic infection. However, higher concentration is achieved in urine and the gastrointestinal tract. That is why the use of Nalidixic acid is restricted to urinary tract infection and the gastrointestinal tract infection. They are lethal to common urinary pathogens and diarrhea causing coliforms. Adverse effects relatively infrequent, consist mostly of the gastrointestinal upset and rashes. Most important toxicities: neurological, headache, drowsiness, anxiety, vertigo, visual disturbance. Occasionally seizure can be seen. Individual with G6PD deficiency, if they take Nalidixic acid, hemolysis may occur. And Nalidixic acid is rarely used nowadays, and their use has been superseded by fluoroquinolones. Now, coming to the drug, fluoroquinolones. What do we mean by fluoroquinolones? Basically, they have got quinolone structure, that is the two benzene ring attached together with the carboxylic acid radical in the third carbon atom. Additionally, there the fluoride radical is substituted at the 6 carbon atom site, and other fluoride substitution can also occur. So these are quinolone antimicrobials having one or more fluorine substitutions. The first generation fluoroquinolones was introduced in 1980s and having one fluoro substitution. Then in the 1990s, more than one fluoride substitution occurred, and what the advantage? They extended the antimicrobial activity. They also included gram-positive ones and the anaerobic ones to gram-positive bacteria and anaerobes, and or conferring metabolic stability, having longer half-life. So what is the advantage of adding the fluoride substitution? Number one, increasing the antibacterial spectrum. Number two, metabolic stability, that is having longer half-life. They are referred to as second generation fluoroquinolones. Some of the new ones having high activity against gram-positive cocci vein. So the fluoroquinolones then were divided into two generations, first generation and the second generation. Second generation had got more than one fluoride substitution or one fluoride substitution and substitution of the carbon atom with other radical also. And what is the advantage of second generation fluoroquinolone over the first generation? They have got longer half-life, they have got extended antimicrobial activity. So these are the first generation fluoroquinolones. Ciprofloxacin is the prototype fluoroquinolone drug. Norfloxacin, Ofloxacin and Pfloxacin. And coming to the second generation fluoroquinolones, Levofloxacin, Moxifloxacin, Gatifloxacin, Trulifloxacin, Lomefloxacin and basically Sparfloxacin. How they are acting? Their primary mode of action is DNA gyrase. They inhibit bacterial DNA gyrase, also called topoisomerase 2, and they also inhibit topoisomerase 4, and topoisomerase 4 inhibition is responsible for their extended antimicrobial activity to the gram-positive organisms. Gyrase nicks double-stranded DNA, introduces negative supercoils and then reseals the nicked ends. This is necessary to prevent excessive positive supercoiling of the DNA strands when they separate to permit replication or transcription. DNA gyrase consists of 2A and 2B subunit. A subunit carries out nicking of DNA, B subunit introduces negative supercoils, and then A subunit they reseals the nicked DNA. Now, fluoroquinolones they have got high affinity to the A subunit of the DNA gyrase, and they interfere with strand cutting and resealing function. After replication, topoisomerase 4 they separate the interlinked DNA strand to be separated in the daughter cells. So they separate the interlinked DNA strand into the daughter cells during cell division. And while DNA gyrase is the primary target of fluoroquinolone action in the gram-negative bacteria, topoisomerase 4 is the primary action of fluoroquinolone against the gram-positive bacteria. Thus, greater affinity of fluoroquinolone for topoisomerase 4, they confers higher potency against the gram-positive bacteria. The mammalian cells have a different topoisomerase 2 that perform the same function of removing positive supercoils, and they have got lower affinity for the fluoroquinolones. That is why they are more selective to the bacteria, not to the host cells. Hence, host cells have low toxicity to the fluoroquinolones. Mechanism of resistance. Number 1, resistance so far is due to chromosomal mutation producing the DNA gyrase or the topoisomerase 4 with decreased sensitivity or decreased basically affinity for the fluoroquinolones. Number 2, reduced permeability of the drug to the bacterial cell membrane or increased efflux of the drug by the bacterial cell membrane. Number 3, resistance to the fluoroquinolone are not easily selected and hence slow to develop, unlike quinolones, Nalidixic acid, where it is fast to develop. So, resistance to fluoroquinolone is slow to develop in contrast to Nalidixic acid. However, increasing resistance have been reported with fluoroquinolones to Salmonella typhi, Pseudomonas, Staphylococci, Gonococci and Pneumococci. Previously, in the typhoid fever, the drug of choice was ciprofloxacin. Now, it is ceftriaxone. So, ciprofloxacin is the most potent first generation fluoroquinolone acting against basically a broad spectrum of bacteria. The most susceptible ones are the gram-negative bacilli, especially the Enterobacteriaceae and the Neisseria. Now, the MIC, what do you mean by MIC? Minimum inhibitory concentration, mane? Is the minimum concentration of drug required to inhibit the bacteria. The MIC of drug against these bacteria is usually less than 0.1 microgram per ml, while gram-positive bacteria is inhibited at relatively higher concentration. So, they are more active against gram-negative bacteria. So, the antibacterial spectrum, they are highly sensitive to E. coli, Klebsiella, Enterobacter, Salmonella typhi, non-Salmonella typhi, Shigella, Proteus, Neisseria, gonorrhea and meningitis, Haemophilus influenzae, Haemophilus ducreyi, Campylobacter jejuni, Yersinia enteropolitica and Vibrio cholera. So, mostly gram-negative ones, gram-negative bacilli. They are moderately susceptible to Pseudomonas. Nalidixic acid did not have any action on Pseudomonas, but they have got moderate susceptibility to Pseudomonas, Brucella, Listeria, Staphylococcus epidermidis, Brandomella, Legionella, Mycoplasma, Chlamydia, Bacillus and Mycobacterium tuberculosis, and low susceptibility to particularly Streptococcus pyogenes, Streptococcus pneumoniae, MRSA, M. kansasi. Resistant bacteria are Bacteroides fragilis, Clostridia, anaerobic cocci. So, they are got no action against the anaerobic organisms. bactericidal activity and high potency. MBCs are close to MIC. What do we mean by MBC? MBC, minimum bactericidal concentration. MIC for inhibiting the growth of the bacteria and MBC for killing. Relatively long post-antibiotic effect on the Enterobacteriaceae, Pseudomonas and staph, low frequency of resistance, low propensity to select plasmid type resistant mutants, and protective intestinal streptococci and anaerobes are spared, less active in acidic pH. Rapidly absorbed orally, food delays absorption although first pass metabolism occur, attain bactericidal concentration in the blood and other tissues with good tissue permeability. Unlike Nalidixic acid, concentration in lung, sputum, muscle, prostate, phagocyte exceed that in plasma, but in CSF penetration and the eye penetration is poor. Excreted primarily in urine, both by glomerular filtration and tubular secretion. Urinary and biliary concentration are 10 to 15 times higher than in plasma. Adverse effect, good safety record, 15% and 10% of the patient can suffer from adverse effect, generally mild, 1.5% require withdrawal of the drug. Mostly are gastrointestinal and central nervous system effect. Gastrointestinal, nausea, vomiting, bad taste, anorexia, diarrhea is infrequent. Central nervous system, dizziness, headache, restlessness, anxiety, tremor, impairment of concentration, dexterity, tremor and seizures are reported rarely but may occur. So, to be used cautiously in seizurogenic patient. It should be used cautiously while driving. The tremor and seizures occur only at high doses when predisposing factors are present. A person had a prior history of seizure on anti-seizure drug, be cautious to use any fluoroquinolone. Again, hypersensitivity reactions that include rashes, urticaria, pruritus, photosensitivity, swelling of lips can be seen. Serious cutaneous reactions are rare. Tendonitis and tendon rupture are seen particularly in elderly subjects more than 60 years and in those receiving corticosteroids. It should be used cautiously in children also because of risk of cartilage rupture. Ciprofloxacin and other fluoroquinolones are contraindicated during pregnancy. Interaction, plasma concentration of theophylline, caffeine and warfarin is increased by ciprofloxacin due to inhibition of metabolism. NSAID may enhance the CNS toxicity of fluoroquinolones. Antacid, sucralfate and aryl salt given together, they reduce absorption of fluoroquinolones. Now, they are effective in a broad range of infection because they have got wide antibacterial spectrum, because of good oral efficacy and good tolerability. They should not be used in minor cases because of risk of development of resistance or when gram-positive organism or anaerobes, they are the primary organisms. Why? Because ciprofloxacin is more active against gram-negative bacteria. In severe infection, we can either start with IV therapy and can shift to oral therapy. Both intravenous and oral formulations are there. Now, uses of ciprofloxacin, it has got a wide use. Number one, urinary tract infection. As we know, they are active against gram-negative bacilli, which are mostly responsible for UTI. So, high cure rates. They can be given in complicated cases having indwelling catheter or chronic prostatitis. Higher success rate than cotrimoxazole. Chronic pseudomonas infection respond less. Now, gonorrhea, they are active 100% curative in non-PPNG, that is penicillinase producing Neisseria gonorrhea, as well as PPNG infections. However, they are less dependable, therefore not used. Chancroid, caused by Haemophilus ducreyi, is the second line alternative drug to the ceftriaxone or the azithromycin. Ceftriaxone, azithromycin are preferred for chancroid. Number 4, bacterial gastroenteritis. Ciprofloxacin is more commonly used for empirical therapy of diarrhea, infective cause. However, it should be reserved for moderate to severe cases. It can even reduce the volume of stool in the cholera patients. Typhoid, chloramphenicol, ampicillin, cotrimoxazole were initially the drug of choice in typhoid fever, but gradually due to development of resistance, they have been withdrawn. In India and elsewhere, up to 95% of the Salmonella typhi isolates are sensitive to ciprofloxacin. Dose 750 milligram twice daily for 10 days. And it has been used as a first line drug. However, the resistance to ciprofloxacin is increasing nowadays. Ceftriaxone or cefoperazone is more commonly used nowadays for treatment of typhoid fever. Intravenous injection can be used in patients unable to take drug orally. Being bactericidal, advantage of ciprofloxacin in typhoid fever is quick defervescence, early relief of symptoms and prevention of carrier state. In case of typhoid carriers, ciprofloxacin is used in a dose of 750 mg BD for 4 to 8 weeks with 92% eradication rate. Coming to the bone, soft tissue, gynecological and wound infection where caused by the resistant Staph aureus and gram-negative bacteria, high cure rate has been seen in a patient of osteomyelitis and joint infection with prolonged therapy. However, higher dose is needed. They are used along with clindamycin or metronidazole. Why? To cover the anaerobic organisms. It is a good drug for diabetic foot even. Respiratory infection is not a primary drug to be used. Why? Because they are not active against the Streptococcus pneumoniae. So, because of Streptococci have low and variable susceptibility, however, it can be used to treat a typical pneumonia like that of macrolides. So, however, it can be used to treat atypical pneumonia. Several second generation fluoroquinolones have now become available with extended antimicrobial activity for the treatment of pneumonia and chronic bronchitis. And ciprofloxacin is a drug of choice in anthrax patient. Tuberculosis. In tuberculosis, basically, they are considered the second line drug. Moxifloxacin and Levofloxacin are the second line drug. Moxifloxacin being more better than the Levofloxacin, and they are used in treatment of the multi-drug resistant tuberculosis. Uh, Ciprofloxacin is less active against M. tuberculosis and is more active against MAC, Mycobacterium avium complex, where the fluoroquinolone most active is ciprofloxacin. Gram-negative septicemia, parenteral ciprofloxacin can be combined with the third generation cephalosporin or an aminoglycoside. Conjunctivitis, topical therapy is effective. Meningitis, CSF penetration is poor, but even then it can be used to treat gram-negative bacterial meningitis, particularly in immunocompromised patients and in those having CSF shunt. It can cure meningococcal carrier state, and they can be used prophylactically in a patient of neutropenic fever. Now coming to the typhoid fever. What are the drugs that can be used for typhoid fever? Currently, the drug of choice is ceftriaxone. So, ceftriaxone is the most reliable, fastest acting bactericidal drug for the enteric fever. Practically all the H. typhi isolates, even the multi-drug resistant ones, are susceptible to the ceftriaxone. Generally, 10 to 14 days treatment is required. Being bactericidal, it also prevents the relapse and the carrier state. It is to be preferred over fluoroquinolone, particularly in children, in the pregnant mother. Why in children? Why in children ceftriaxone should be preferred over fluoroquinolone? Because there is an adverse effect of fluoroquinolone in children. Cartilage damage. So they should not be used in children. So it is to be preferred over fluoroquinolone in children, pregnant mother, and in areas with fluoroquinolone resistance. It has to be injected intravenously 2 grams twice daily for 2 days, followed by 2 grams per day till 2 days after the fever subsides. In children, 75 milligram per kg per day is the dose. Alternative to the ceftriaxone, cefoperazone or cefotaxime can be used. Fluoroquinolone is a second drug. Ciprofloxacin is mostly used 750 milligram BD when we treat a typhoid fever case in an OPD basis. Then ciprofloxacin is the drug of choice. So ciprofloxacin 750 milligram BD is mostly used. Ofloxacin and levofloxacin are nearly equally efficacious. Azithromycin is used in multi-drug resistant typhoid, where the dose is 500 milligram OD for 7 days, and in patients to whom first line drug cannot be given. Chloramphenicol, initially it was the drug of choice, but because of rapid development of resistance, the drug has been withdrawn. Cotrimoxazole, it was effective in typhoid till plasmid mediated multi-drug resistance developed. Nowadays, it is rarely used. Now coming to the second fluoroquinolone, that is norfloxacin. Norfloxacin is the least potent fluoroquinolone, even with the ciprofloxacin. MIC value for most gram-negative bacteria are 2 to 8 times higher than that of ciprofloxacin. Many pseudomonas and gram-positive organisms are not inhibited, and the concentration attained in most of the tissues, they are non-therapeutic. They are primarily used for urinary tract infection and the diarrhea case. So primarily used for urinary tract infection, given for 8 to 12 weeks, it can treat even chronic UTI. It is also good for bacterial diarrhea because high concentrations are present in the gastrointestinal tract and anaerobic flora are not altered with the use of norfloxacin. That's an added advantage. Coming to the pfloxacin, it is a methyl derivative of norfloxacin, more lipid soluble, so more tissue penetration, completely absorbed orally, penetrate tissue better, and attains higher plasma concentration, and passage into the CSF is much better compared to other fluoroquinolones, so they can be used for meningeal infection event. Highly metabolized partly to norfloxacin. It has longer half-life and they are effective in some systemic infection as well. Those need to be reduced in liver disease but not in renally impaired patient. Ofloxacin somewhat less effective than ciprofloxacin against gram-negative bacteria, but they have got extended spectrum against gram-positive bacteria, equally or more potent against Streptococcus pyogenes and other gram-positive cocci, and they are active against certain anaerobes even. Good activity against chlamydia and mycoplasma has been noted. So, ofloxacin is also used in chlamydia cervicitis and urethritis. Alternative drug for non-specific urethritis, cervicitis, and atypical pneumonia caused by chlamydia trachomatis. It also inhibits Mycobacterium tuberculosis, so the drug is used as in the treatment of multi-drug resistant tuberculosis. In resistant case of TB, high activity is exhibited against M. leprae. So it is used in alternative multi-drug resistant leprosy regimen. Relatively lipid soluble, oral bioavailability is high, they attain higher tissue penetration, food does not interfere with absorption, dose need to be reduced in renal failure. Now it is comparable to ciprofloxacin in the treatment of systemic infection, in the treatment of chronic bronchitis, respiratory infection, ENT infection, as well as for chlamydia urethritis as an alternative drug. Levofloxacin is the levo isomer of the ofloxacin. They have got improved efficacy against Streptococcus pneumoniae, Mycobacterium tuberculosis, certain gram-positive bacteria and anaerobes. Anaerobes are moderately susceptible. Oral bioavailability is 100%. So the intravenous dose and the oral dose are similar, mainly excreted unchanged. Single daily dose is sufficient. Primary indication is community acquired pneumonia and exacerbation of chronic bronchitis, and they have got great success in even sinusitis, pyelonephritis, prostatitis, and other urinary tract infection. It is an alternative drug for chlamydia trachomatis, urethritis. It is the second most active fluoroquinolone against tuberculosis. First active ki ache? The most active fluoroquinolone against Mycobacterium tuberculosis is Moxifloxacin, and the second is Levofloxacin. So it is the second most active fluoroquinolone for tuberculosis, and in India it is a component of standardized regimen in the multi-drug resistant tuberculosis. Moxifloxacin is the long-acting second generation fluoroquinolone active against Streptococcus pneumoniae, against gram-positive bacteria including beta-lactam macrolide resistant pneumonia and some anaerobes. It is most potent fluoroquinolone active against Mycobacterium tuberculosis and is extensively used in MDR-TB. Bacterial topoisomerase 4 is the primary target of action. So they are more active against gram-positive than gram-negative ones. Primarily used for pneumonia, bronchitis, sinusitis, otitis media. Not used for UTI, urinary tract infection है moxifloxacin है कोनो role नहीं. Why? Because the urinary concentration of moxifloxacin is very low. Primarily metabolized in liver, so should not be given in liver disease patient. Renal failure patient है dose modification दरकार नहीं. In moxifloxacin, side effects are similar to that of fluoroquinolones. It should not be given to patient predisposed to seizure. Many fluoroquinolones are seizurogenic, so they should be avoided in patients of seizure. So they should not be given to patients predisposed to seizure and to those receiving pro-arrhythmic drugs. Problem with moxifloxacin is that they prolong QTC interval. When you combine the drug with other pro-arrhythmic drugs, it can prolong QTC interval more, and that can lead to fatal arrhythmia. Gamifloxacin is again a long-acting second generation fluoroquinolone. It is a broad spectrum fluoroquinolone mainly active against gram-positive bacteria, especially Streptococcus pneumoniae, H. influenzae, Moraxella, Mycoplasma, Chlamydia, Klebsiella. Some anaerobes are also inhibited. Now, rapidly absorbed, undergoes limited metabolism, excreted in urine as well as feces, both as unchanged drug and as metabolite. Those need to be halved if creatinine clearance is less than 40. Side effects are similar to that of other fluoroquinolones: diarrhea, nausea, headache, dizziness, and rise in serum transaminase. Skin rashes can be seen. It can enhance warfarin effect, carry the risk of additive QT prolongation like that of moxifloxacin. Indicated for community acquired pneumonia and exacerbation of chronic bronchitis. Prolifloxacin is a newer second generation fluoroquinolone, is a prodrug of olifloxacin, having a broad spectrum antimicrobial activity against both gram positive as well as gram negative organisms, including many resistant strains. Rapidly absorbed, converted to olifloxacin, and during the first pass metabolism excreted primarily unchanged in urine. Primarily used for pneumonia, exacerbation of chronic bronchitis, complicated and uncomplicated urinary tract infection. Side effects similar to that of ciprofloxacin, that is gastrointestinal, neurological and hypersensitivity reactions can be seen. Claim not to prolong QT interval.